Welcome back to the Capnography tutorial. This is part 5. In part 4, we talked about how you can use capnography to monitor ventilation. I think most everybody kind of grasps that concept. It's not too difficult to understand. Now we're going to talk about how you can use capnography to monitor circulation. Okay? And the ultimate circulatory compromise is the cardiac arrest patient. Okay? So if you got somebody in cardiac arrest and you're monitoring capnography, you could suspect low values. Okay? But as you're working that patient and as you're doing CPR, as the values increase, that is a good indicator of good CPR. And think about what that means. As you get a higher end-tidal CO2 value, it's an indication of higher quality CPR. And what is the most important thing we do for a cardiac arrest victim? It's CPR. So wouldn't you want to get these values on your patients to know that you're giving better CPR? I mean, to me, it seems like a dead set, easy answer. Yes, of course. Get a capnography value, and as you're doing CPR on these patients, for instance, let's say that they have an initial value of about 10, all right? And they're in cardiac arrest. That's a low value. They definitely are in cardiac arrest if they got a value of 10. So you get that value, you start doing CPR, and you notice the values start coming up, 15, maybe 20, maybe 25. You see values like that, you know you're doing good CPR. In fact, if you've got that kind of change, if you get values that start going up, it's a good indicator that this is a viable patient, that this patient can survive if you get a pulse back. How do you know you get a pulse back? Well, a spike in end-tidal CO2 is a good indicator. Obviously, you're going to feel for a pulse. But if you get a spike in end-tidal CO2 values on a cardiac arrest patient, that is a super good indicator of ROSC, return of spontaneous circulation. So suspect an increase in perfusion and possible perfusable rhythm with an elevated CO2 level. We've seen this image before in the earlier parts of this tutorial. With cardiac arrest, we have a stop sign at the circulation component. Remember, if you can't circulate the CO2 back to the lungs, you're not going to get a good end-tidal CO2 reading. So that's why we say if you have low cardiac output, low circulation, you'll get low end-tidal CO2 readings. Here's kind of a good image here that helps understand as you get lower cardiac output levels, this is liters of blood I'm guessing here, lower cardiac output levels, you get lower end-tidal CO2 readings. Okay? It doesn't mean just because you have somebody that's hypocapnic, they have a low end-tidal CO2 reading, it doesn't necessarily mean for sure that they have a circulatory issue. They could have a ventilation issue. They could have a cellular metabolism issue. So you have to use everything. This is just one of your assessment tools that's going to help you identify an issue. So with your cardiac arrest patient, here's what happens when you get that spike in return of spontaneous circulation. You'll have a constant low value as you're doing CPR and as you're ventilating the patient, because obviously if you're not ventilating them, you're not going to get any value. So all of a sudden you have these low values, and then boom, you get this spike. That's an indication to check for a pulse. What's happening? The CO2 is present, okay? Because in your cardiac arrest patient, they have oxygen, they've metabolized that oxygen. It's just now the CO2 is just sitting stagnant. It's not being moved around. And suddenly, as you regain a pulse or start CPR or however you want to circulate that blood, suddenly as you do that, that CO2 is going to make it to the lungs, and it's going to give you this really high reading, okay? Conversely, if they didn't metabolize the CO2 yet and they suddenly get a pulse back, they're going to metabolize it, the oxygen. They're going to metabolize the oxygen, and they're going to send that CO2, back to the lungs and out into your device, giving you a high capnography reading. Conversely, a sudden drop in end-tidal CO2 is a good indication to check for a pulse. Imagine this. You've got a patient who's unstable. Let's say they're unresponsive. You have them intubated, and you're heading to the hospital. And you have okay capnography readings initially, and then all of a sudden you get a plummet in their capnography readings. You're still ventilating them, but you have a low value. You need to check for a pulse on that patient because they may have lost one on you. And it's a good thing to pick up on rather quickly, wouldn't you think? So check for a pulse with a sudden drop or a sudden increase, because the sudden increase, it would be for your cardiac arrest patient, you can check for pulse, check for ROSC. And the sudden decrease in end-tidal CO2 could be an indication that you lost a pulse. Here's some research. You can read over this if you want. If you have a value of 10 for your cardiac arrest patient or less, if you never come above the value of 10 millimeters of mercury for an end-tidal CO2 reading for 20 minutes, for a whole 20 minutes of working a cardiac arrest, you need to consider termination if your system will allow you to do that, because this patient will not survive according to the literature. So values of less than 10, 20 minutes into a cardiac arrest resuscitation effort will not be correlated with a survivable patient or a viable patient. More research shows that nobody in this study survived with that condition if they had values of less than 10. But in all 35 patients who did survive, they had values of at least 18 before they had a detectable return of vital signs, so of a pulse. You need to think of asphyxic versus cardiac arrest patients. Remember, the asphyxic patients are usually your kids going to cardiac arrest. The pediatric cardiac arrest that you run, they're going to be due to asphyxia or some sort of respiratory compromise. They have higher end-tidal CO2 readings initially on the monitor. So don't think that they're, just because their values are so high, that it's a different correlation. They're usually because they weren't exhaling that CO2 initially. The number will come down within the first minute of CPR. So don't think that you doing CPR is actually hurting them or it's not effective on the asphyxic arrest patient. End-tidal CO2 monitoring can provide an early warning sign of shock. All right, I've kind of spoken about that. If you suddenly get a decline in end-tidal CO2, your patient might be in shock. Also, if you run, let's say you run on a septic patient, somebody that's got a super high fever, or maybe they're hypothermic. Remember, septic patients can be hypothermic. Let's say you run on these patients and they've got a known infection and they've got really low end-tidal CO2 values. That patient has an actual low indication of survivability. They might die soon after your care, not on you, but in the hospital, because that low value is an indication of septic shock in those patients. So just use end-tidal CO2 to monitor circulation as well as ventilation, because it can indicate that these patients are going into shock or cardiac arrest. A pulmonary embolism, that's considered a VQ mismatch in a way. Pulmonary embolus will cause an increase in the dead space in the lungs, decreasing the alveoli available to offload carbon dioxide. The end-tidal CO2 will go down. This kind of helps because you can have somebody that's got a pulmonary embolism with normal oxygenation. These patients sometimes will present with 100% O2 sats, and you might not hear any difference in lung sounds with a pulmonary embolus. So what do we use? Capnography. That can actually help you. If their story fits pulmonary embolism, for instance, if they had a sudden onset of shortness of breath, young girls that smoke who are on birth control are at high risk for pulmonary embolism. Anybody with recent surgery is at high risk for pulmonary embolism. People with swollen legs in the pendant areas, you'll see that they have a high incidence of DVTs, of deep vein thrombosis, and they tend to have pulmonary embolisms. So if you see this happen, if you see a decrease in levels due to this alveolar dead space, you're not going to see obviously this image happen just like this, but you got to think, okay, are they having a pulmonary embolism? And if they are, you may see a change in your capnography that correlates with this image. Well, that's it for part 5 of the capnography tutorial. We're going to do another part after this and continue on learning about capnography. I hope to see you there.